Once again, welcome to ReviseMed YouTube channel for Pharmacology. In this episode, we are going to see an important topic, namely Pharmacodynamics. There may be two essay questions from this particular chapter. One is mechanisms of drug action, and another essay question is factors influencing drug effect. There may be several short notes from this particular topic. So kindly go through the episode seriously. Pharmacodynamics. We know pharmacodynamics is what the drug does to the body. If we go into detail, pharmacodynamics is the study of the biochemical, cellular and physiological effects of drugs and their mechanisms of action. Pharmacodynamics can be dealt in two aspects, in two ways. One is qualitative aspects of the topic, that is dealing with the receptors, enzymes and selectivity, and the other is quantitative aspects of pharmacodynamics, that is dose response, therapeutic efficacy, potency, tolerance, etc. One may ask, what is the significance of understanding pharmacodynamics? Understanding pharmacodynamics provides the basis for rational therapeutic use of a drug and design of new superior therapeutic agents. What are the types of drug actions? Stimulation, example, adrenaline stimulates heart, depression, alcohol depresses CNS, irritation, counter-irritation in pain bombs, replacement, insulin in diabetes mellitus, chemotherapeutic agents like antibiotics, then immunomodulation done by vaccines, sera, glucocorticoids. Now coming to mechanism of drug action. Mechanism of drug action can be dealt under two topics. Mechanism of drug action mediated through receptors and mechanism of drug actions mediated through non-receptors. Under non-receptors, drug actions are mediated by enzyme inhibition, inhibition of transporter processes, incorporation into larger molecules, altering metabolic processes, chemical action, physical action, and others. Coming to receptor-mediated mechanisms, we must know what's a receptor. Drug receptor or drug target. Drug receptor or drug target denotes a cellular macromolecule or macromolecular complex with which the drug interacts to elicit a cellular or systemic response. Where do you find receptors? Drug receptors may be located on the cell surface, cytoplasm, nucleus, etc. For instance, adrenaline acts by stimulating adrenoceptors. Now coming to non-receptor mediated mechanisms, drugs may act on processes within or near the cell by 1. Enzyme inhibition. Example, platelet cyclooxygenase inhibition by aspirin. Then cholinesterase inhibition by pyridostigmine. Xanthine oxidase inhibition by allopurinol in gout. Angiotensin converting enzyme inhibitors such as enalapril act by inhibiting ACE, angiotensin converting enzyme, and used in treatment of hypertension. 2. Inhibition or induction of transport processes. These transport processes carry substances across and out of cells. Some drugs bind to ion channels and bring about a drug action. Example, local anesthetics bind to sodium ion channels in neural membrane and produce local anesthesia. 3. Incorporation into larger molecules. Example, 5-fluorouracil is an anti-cancer drug which gets incorporated into messenger RNA of the cell in place of uracil and brings about anti-cancer effect. 4. Altering metabolic processes. Anti-infective drugs like antibiotics, antivirals, antiparasitics achieve specificity by targeting receptors or cell processes that are critical for the growth or survival of the infective agent, but are non-essential or lacking in the host organism. Classical example will be penicillin acts by inhibiting cell wall synthesis in bacteria. Outside cell, drugs may act by one chemical action. Example, chelating agents, antacids, oxidizing agents, etc. 6. By physical action, we take osmosis. We have osmotic purgatives like magnesium sulfate, osmotic diuretics like mannitol. Then by physical action, we are using radioactive iodine 131. Activated charcoal is used as an adsorbent. So these are examples for physical method of action by drugs. Now coming to other mechanisms, first Therapeutic biologics. A large percentage of new drugs are genetically engineered enzymes and monoclonal antibodies. They are no more small molecule drugs. For instance, live oncolytic herpes virus injected into tumors to destroy tissues that cannot be removed with surgery. Then gene therapy products use viruses as vectors to replace genetic mutation. Immune modulation. Vaccines and sera act by antibody production. Glucocorticoids act by immunosuppression. We may know some qualitative aspects of receptor families. Ligand-gated ion channels. Receptors coupled directly to membrane on ion channels. Neurotransmitters act on such receptors in postsynaptic membrane of a nerve or muscle cell and give a response within milliseconds. This group of receptors include nicotinic-cholinergic receptor, gamma-aminobutyric acid receptors, etc. Now coming to G protein coupled receptor, this may be asked as a short notes. These are receptors bound to cell membrane and coupled to intracellular effector systems by a G protein. For instance, catecholamines serve as a first messenger. They activate beta adrenoceptors through a coupled G protein system. This increases activity of intracellular adenyl cyclase, increasing rate of formation of cyclic AMP, which serves as the second messenger. This is a modulator of activity of several enzyme systems that cause cell to act. This process takes seconds. Because of their number and physiological importance, G protein coupled receptors are widely used targets for drugs. Half of all non-antibiotic prescription drugs are directed towards these receptors that make up the third largest family of genes in the humans. Protein kinase receptors, largest group of receptors with intrinsic enzymatic activity. It is called protein kinase receptors because the structure incorporates a protein kinase. Targets for peptide hormones involved in control of cell growth and differentiation and release of inflammatory mediators over a course of hours. Receptors of this group include cytokine receptors, growth hormone receptors, multi-subunit antigen receptors on T and B lymphocytes, and interferon G receptor. Cytosolic or nuclear receptors. These are present within the cell itself. Regulate DNA transcription and there will be protein synthesis. Example, they regulate the synthesis of steroid and thyroid hormones, a process that takes hours or days. Receptors for steroid hormone, thyroid hormone, vitamin D and retinoids are belonging to this group. Now coming to receptor regulation. Number of receptors may go down or go up. Down regulation or up regulation. So receptor numbers change according to circumstances. What is down regulation? When tissues are continuously exposed to an agonist, the number of receptors decreases. This causes tachyphylaxis, that is loss of efficacy with frequently repeated doses. Example, in asthmatics who use adrenoceptor agonist bronchodilators have less effect in course of time. Upregulation. Prolonged contact with an antagonist leads to formation of new receptors. One explanation for the worsening of angina pectoris in some patients following abrupt withdrawal of a beta blocker is that normal concentration of circulating catecholamines now have access to an increased upregulated population of beta adrenoceptors. We must know some definitions. What is ligand? A molecule that selectively binds to a specific receptor. Drug targets are termed physiological receptors. What is agonist? Drugs that bind to physiological receptors and mimic the regulatory effects of the endogenous signaling compounds. What is affinity? Ability of the drug to get bound to a receptor. Intrinsic activity. Ability of the drug to produce a pharmacological effect after combining with the receptor. Agonist as affinity plus intrinsic activity. What is full agonist? An agonist with maximal efficacy. Partial agonist, an agonist with less than maximal efficacy. Some drugs have both antagonist and agonist action. Such substances show partial agonist activity. Beta adrenoceptor antagonists, pindolol and oxprinolol, have partial agonist activity. Propranolol is devoid of agonist activity, that is, it is a pure antagonist. Inverse agonists produce effects that are specifically opposed to those of agonist. Agonist action of benzodiazepines on benzodiazepine receptor in central nervous system produces sedation, anxiolysis, muscle relaxation, and controls convulsions. But substances called beta-carbolines, which also bind to this receptor, cause stimulation, anxiety, increased muscle tone, and convulsions. They are called inverse agonists. Both types of drugs act by modulating effects of neurotransmitter gamma-aminobutyric acid. Antagonist has affinity but no intrinsic activity. What is synergism and antagonism? When two or more drugs are given concurrently, effect may be additive, synergistic, or antagonistic. What is additive effect? Total effect is sum of individual effects. That is simple addition. 1 plus 1 is equal to 2. Ephedrine plus theophylline is an example. Synergistic effect. Total effect of combination is more than sum of individual effects. That is 1 plus 1 is equal to more than 2 or 3. Often called potentiation or superadditive effect. Classical example will be acetylcholine with physostigmine. Antagonism. One drug opposing action of another drug. One chemical chelating agents antagonize heavy metals. 2. Physiological antagonism, histamine versus adrenaline. 3. Antagonism at receptor level. There are two types, reversible competitive and irreversible non-competitive. Antagonists. We must know some details about antagonists. Antagonists interact with the receptor but do not produce a response. They have affinity but no efficacy. Drugs that have no activating effect on receptor are termed pure antagonists. A receptor occupied by a low efficacy agonist is inaccessible to a subsequent dose of a high efficacy agonist. So that in this specific situation, a low efficacy agonist acts as an antagonist. This can happen with opioids. What is competitive or reversible antagonists? These antagonists compete for a site on receptor already occupied by an agonist. Duration of action of a reversible antagonist is closely correlated with its rate of elimination. As it gets eliminated, concentration at its site of action falls and there is less of it to compete with the agonist. Acetylcholine and atropine at muscarinic and acetylcholine and tuberculin at nicotinic neuromuscular junctions will be examples. Non-competitive or irreversible antagonist. These antagonists prevent binding of an agonist or prevent agonist from activating the receptor. Duration of action of an irreversible antagonist is determined by the rate of synthesis of new receptors because all the receptors are irreversibly occupied. Decreases maximal response obtained with an agonist alone. Drugs that bind irreversibly to receptors include phenoxybenzamine to the adrenoceptor. Whatever may be the amount of adrenaline used, it cannot be overcome. Physiological or functional antagonism. Two drugs act at two different sites to produce opposing effects. Extreme bradycardia following overdose of a beta-adrenoceptor blocker can be relieved by atropine that acts by blocking muscarinic 2 receptors. Adrenaline and theophylline counteract bronchoconstriction produced by histamine released from mast cells in anaphylactic shock by relaxing bronchial smooth muscles through beta-2 adrenoceptor effect. So here adrenaline relaxes, histamine constricts, both acting on two different receptors. So they are physiologically opposite. In both cases, a second drug overcomes the pharmacological effect by a different physiological mechanism. That is, there is physiological or functional antagonism. Effectiveness, toxicity and lethality. ED50 is median effective dose 50. This is dose at which 50% of population or sample manifests a given effect. Toxic dose 50, TD50, is median toxic dose 50. Dose at which 50% of the population manifests a given toxic effect. Lethal dose 50 or deadly 50 is median toxic dose 50, median lethal dose 50. Dose which kills 50% of the subjects. Therapeutic index is a comparison between ED50 and TD50, that is effective dose 50 and toxic dose 50. Therapeutic index is a value that indicates relative safety of the drug. Therapeutic index is calculated by dividing LD50 by ED50. The higher the therapeutic index, the better the drug and its safety. Therapeutic index vary from a score of 1 to more than 1000. Example for drugs with low therapeutic index, we can say digitalis, lithium, phenytoin, aminoglycosides, and some anti-cancer drugs. Drugs with a high therapeutic index, penicillin is one among them. Such therapeutic indices are of great value when toxicity is an extension of pharmacological effect. Efficacy, that is pharmacological efficacy, refers to strength of response induced by occupancy of a receptor by an agonist, intrinsic activity. For example, if drug A can produce a therapeutic effect that cannot be obtained with drug B, whatever the amount of drug B is given, then drug A has the higher therapeutic efficacy. Potency. Potency is the amount in weight of a drug in relation to its effect. Example, if weight for weight of a drug A has a greater effect than drug B, then drug A is more potent than drug B. Example, the diuretic effect of butyramide 1 mg is equivalent to that of furosemide 50 mg. Thus, bumetanide is more potent than furosemide. Now we are coming to a major question. Factors that modify drug effects. Now you must remember factors that modify drug absorption, factors that modify drug availability, bioavailability. Under factors that modify drug effect, first we consider age, neonate, infant and child. Young human beings differ greatly from adults, not merely in size, but also in proportions and the constituents of their bodies and the functioning of their physiological systems. In elderly, incidence of adverse drug reactions rises with age in adult, especially after 65 because of the increasing number of drugs they take because of their conditions. They may be having hypertension, diabetes and other complications. So they will be taking a lot of drugs. Then 2, poor compliance with dosing regimens. 3, bodily changes of aging that require modified dosage regimens. In pregnancy, as pregnancy evolves, profound changes occur in physiology, including fluid and tissue composition. So, there may be a corresponding change in prescription of drugs and their activity. Pharmacokinetic factors regarding absorption. Malabsorption of iron, folic acid and fat-soluble vitamins after partial gastrectomy and vitamin B12 malabsorption after ileal resection. Under distribution, hypoalbuminemia from any cause, example burns, malnutrition, sepsis, allows a higher proportion of free unbound drug in plasma. Kindly think of free warfarin. Under metabolism, acute inflammatory diseases of liver, viral, alcoholic and cirrhosis affect both the functioning of the hepatocytes and blood flow through the liver. Please think of first pass metabolism. Elimination. Renal disease has profound effects on the elimination and duration of action of drugs eliminated by the kidney. Pharmacodynamic factors. Asthmatic attacks can be precipitated by beta-adenoreceptor blockers. Myocardial infarction predisposes to cardiac arrhythmia with digitalis glycosides or sympathomimetics. Myasthenia gravis is aggravated by quinine and quinidine. Food. Presence of food in stomach, especially fatty food, delays gastric emptying and absorption of certain drugs, example ampicillin and rifampicin. Calcium in milk interfere with the absorption of tetracyclines and iron by chelation. Some specific dietary factors induce drug metabolizing enzymes, example alcohol, charcoal, grilled beef, cabbage and Brussels sprouts. Protein malnutrition causes changes that are likely to influence pharmacokinetics, example loss of body weight, reduced hepatic metabolizing capacity, hypoproteinemia. Drugs. Drugs that have a steep dose response curve and a small therapeutic index lead to substantial changes in effect, example digoxin or lithium. Drugs that are known enzyme inducers or inhibitors have their own effect on the influence of drugs. Drugs that exhibit saturable metabolism, that is zero order kinetics, when small interference with the kinetics may lead to large alteration of plasma concentration. Example phenytoin, theophylline. Tolerance. Continuous or repeated administration of a drug is often accompanied by a gradual diminution of the effect it produces. So, a state of tolerance exists when it becomes necessary to increase the dose of a drug to get an effect previously obtained with a smaller dose, that is reduced sensitivity. Enzyme induction leads to tolerance. Regarding tachyphylaxis, tachyphylaxis describes the phenomenon of progressive lessening of it, that is refractoriness in response to frequently administered doses. It tends to develop more rapidly than tolerance. Huge dose of morphine may be required in relieving pain of cancer patients. Even if you increase the dose of morphine, there may not be the same effect. So, huge dose of morphine that may be necessary to maintain pain relief in terminal care due to reduced effect, may be due to down regulation of receptors. Thank you very much.